going to talk about a current project that I'm involved with. I'm actually managing this project in Cambridge. The project is called SHIMI, and it's shared decision making in psychiatric medication management. When I gave this presentation in Warsaw, Moita was there, but she's not here. I came with a service user who works with us in the project. Because, and usually when I talk about it, I do it with at least one service user. Because this project was born out of a group that was called Coming Off Medication, Coming Off, that was started by a service user and a nurse. It was a community group. People could come and talk about their own issues with medication. Quite often, family members would come, and they also invited professionals to talk about aspects of taking medication, how to say no, how to come off, things like that. They tried to get a budget to have the group on a regular basis. They couldn't get the budget. Each of us was asked, what can we contribute to the work of the group? And I said, I can contribute knowledge of research. And then the idea that we will try an intervention that would include a process of shared decision making on medication. And we will apply for funding to the National Health Service in the UK. And we will do it all together with members of that group, with people from the trust, and with researchers. We are surprised that we got the funding, but we did get the funding. So the question is, what did we do with the funding? So this is a group from the beginning that has 5 service users, 3 of whom are on the management team of the group. It also has 3 psychiatrists, it has 3 nurses, and it has 2 senior researchers and 2 more junior researchers on the team. Most of the people come from the trust, and the people from the university are the researchers, basically. The trust doesn't seem to have researchers. It does, but not in this area. Okay. So we have chosen medication not just because the group was about coming off, because medication is the most dominant intervention in mental health in the UK. And I don't think it's any difference in Slovenia. And I think that to ignore this fact is misleading. We can't say medication doesn't exist in our life because we don't like it. It not only does exist, it's actually the use of medication is a way not to offer other interventions. And we've got to understand it, that it's not a world in which everything can coexist. It's a world in which, for a variety of reasons, including the belief of the public in the value of medication. And we know when we have a physical illness, we run to the doctors. So, it's not so extraordinary as it may sound. But the dominance of medication means that there is no readiness to invest seriously in other interventions. There are some other interventions. There are psychological interventions mainly. There are some social interventions of social inclusion projects, of enabling people to move into employment. But they are really on the margin. And it's the medication which is the first and the last thing, if you want. So the question is, what can be done about it? What is shared decision making? It's a process of sharing information, experience, and preferences in which the decision is not known in advance. It's not that I, as a psychiatrist, know what will happen at the end, if it's through this shared decision making. Or I, as the patient, know. But we both enter it because we wish to find another solution. And there is a description here. Charles and Gaffney are American researchers and wrote about it quite a lot. And they say at least two people share information, take steps to build a consensus, an agreement, and reach an agreement. But in reality, there are many cases in which an agreement is not shared, it's not reached. And that the best decision is to disagree to reach a decision. So this is really problematic in a field where the public gives the mandate to psychiatrists to decide for people. A lot of us are happy that someone else is making the decision. A lot of us are unhappy but do not really know what to do about it. And more than that, I will come back to this slide. We have a lot of evidence. I will come to it later, just to say. We have a lot of evidence. 50% of mental health patients in the UK, in Italy, do not take the medication. Or they take it from time to time. But they don't tell the clinician. So the result is a dishonest relationship. You know, this is to call it by its name. Usually people don't like to use such words. They are too emotive. But this is the outcome. People don't feel they can tell the psychiatrist what they really think about the medication. They feel that the only thing they can do is this type of passive resistance, not take the medication. Quite often the psychiatrist is able to tell after some weeks that people are not taking medication. There's maybe a regression, there may be, if they do blood tests, the change in the blood test, all sorts of things. And then the problem for the psychiatrist is how to bring it up if there hasn't been a crisis, because the psychiatrist is sure there will be a crisis. So the scenario we had before, where each of us wrote how we are not going to go to hospital, is not a particular reality here. Because psychiatrists are convinced that if people will not take the medication, nearly all of them, they never say 100%, but they would say something like 95%, people will relapse and will go into a crisis. And to prevent the crisis, we have to give people medication against their will. This is possible in English law, it's possible in Slovenian law, and in the UK situation, it's psychiatrist, the family doctor, and the social worker who are making that decision. Whether the person needs to go to hospital because they are at a danger to themselves or to others, or both. And people are taken regularly back, and they are given medication against their will. All of them experience this as a very intrusive, insulting experience. The description of people of what it was like to be taken inside by coercive means is always horrible. It's the most horrible experience they can talk about. So there are quite a lot of issues to consider here. On the one hand, the wish of people not to take the medication, the assurance of psychiatrists that they must take the medication, and quite often if people have psychosis of different types, they are told you're going to stay on it for life. The reason why people don't want to be on medication, there's a long list. There are what psychiatrists call side effects and other people call adverse effects. People put on weight in 3 months people put on 3 stones for some type of medication.
How much
They
is
are
that in
hungry
kilos?
all the time.
3 stones in kilos.
Well, a stone is 12 kilos or something like that.
Seven, I think, that it's...
Yeah,
A kilo is 2.5 pounds. A stone is 7
2.2.
pounds. No, not 14 pounds.
A kilo is 2.2.
Kilo is 2.2. Yeah.
So 20 kilos.
20 kilos, yeah. People, libido disappears. People are not able to function sexually. Quite often people sleep all the time, have difficulties in getting up. If they continue to take medication, there are involuntary movements, hands, face muscles, legs. There's a long, long list. There are also some other, in many ways, more serious issues that people can have heart attacks if they continue to take medication, because some medication show a very close association. If you continue to take the drug for more than 6 months, the likelihood you will have a heart attack is very high. Some people develop diabetes as a result of taking the medication. So when people say they don't want to take medication, they have good reasons. Either, subjective or objective. But when psychiatrists say that you have to be on medication, they feel that they know what they're talking about. They have been trained to give medication. The rest of us, in a sense, the professionals, we know much less about medication. Over the years, maybe we learn more, but we are in an inferior position in this discussion. So, to come back, the UK Ministry of Health thinks that shared decision making is a very good idea. But it hasn't done anything to make sure that it will happen. Ethically, shared decision making is certainly the right thing to do in terms of recognizing that that no decision can be taken about people without the people themselves. This is a very basic principle of ethical coexistence. However, in the UK, there are no evaluated shared decision-making interventions about psychiatric medication. In the world, there are two studies in Germany which are randomized control trials sampling, i.e. they take what they call representative sample. One in an acute admission ward, where the guy who did it, the team, they created a very short manual of what you need to do to make shared decision making, to be better informed, to discuss it with other people, to bring your views to the meeting with the psychiatrist, all of that. And what the study showed, there was a follow-up after 18 months. It didn't harm anybody, including the people who decided to stop the medication. But quite a lot of people didn't actually want any change in their medication. And those who didn't reach shared decision, at the end felt the need to follow what the doctor told them. The second study is in depression, treating depression in primary care with family doctors, also with a representative sample. That study shows not only that there was no harm, but quite a lot of satisfaction by the patients that there was a process of shared decision making. It didn't make any difference to the outcomes. What happened to them before the trial, before the intervention, and a year later was the same. So it didn't make any difference. There are some other attempts. Patricia Deegan, whom I mentioned yesterday, together with Robert Drake and Charles Rapp. Robert Drake is a psychiatrist specializing in employment. And Charles Rapp is the guy who started the strengths approach in mental health, who is a social worker, professor of social work. They have teamed together to create a way of a computerized program that gives people who are using mental health services the tools to decide what their priorities are, what they want in life, and then in terms of well-being, in terms of medication, in terms of the illness, in terms of advanced directive. And to come with that, it's called Common Ground. Everyone can get to that website if you want. Just do either Patricia Deegan or www Common Ground and you will get them. And they go with those filled-in questionnaires or forms to the meeting with the psychiatrist. At a later stage, they train the care coordinators to do that with people. But they have actually not worked directly with the psychiatrist at this stage. There is now a big trial in a voluntary organization, in a not-for-profit organization in the United States, where they are trying those forms with a large sample. It's never been tried in a statutory service. In the UK, most of our work is in statutory services. It's public sector, but it's a service where people have to be referred to, and it's actually full of professionals. Yeah, and it's certainly not a voluntary organization. Let me just go back for a minute to show you in a diagram way what the ideal of shared decision looks like. It's a meeting of two experts. One is an expert in experience, the lived experience of mental ill health. The other one is a practitioner, expert in medication. And in this case, it could be anything else. And they exchange knowledge. They get from each other information. They exchange views about what to do with that information. And then they reach a decision. It's very nice if they reach a shared decision, they agree on something, or the shared decision is not to agree. Okay? This is the ideal. Yeah. So, the whole idea of shared decision making started in the field of cancer. In the field of cancer, where people have to take decision about life or death. It's very stark. The clinicians are much more ready to allow those people to reach those decisions themselves. They are there to support them, to give them the information, to do with them the process of looking at advantages and disadvantages. But they actually leave to them the decision. And O'Connor is a guy in Canada who started this way of working. There is a questionnaire and there's a systematic way that people reach decisions or say how they reach decision in a conflictual situation. Because the decision about the life or death, whether to take the treatment which is on offer or not, is a conflictual decision by definition. And this is used all over the world. The sample is enormous. We are talking about thousands of people, doing this process in cancer counseling. And there is a movement in the UK to use more shared decision making in primary care, not only about cancer. I'm very critical of it openly because the observer of whether it is shared decision making is only a professional. In my book, this is not about shared decision making. I'm sure I'm not popular. We have some interesting example people who, this is a study, the previous study is about 6 European countries, 6 sites, where they follow the agenda of the client in the meetings for a year. Whatever the client said we would like to discuss, this is what they discussed. And afterwards they did look at the outcomes, compared with clients where this was not an option, but who got any other intervention. And those whose agenda was taken seriously did much better in terms of mental health outcomes. So this is quite an interesting study for us, because it's about the importance of what happens when you actually give the client the power to influence the process, not simply the decision, the process itself, and what you are discussing. So, there's a lot more in terms of evidence. Just one more thing that I'm going to mention before we look at our study. The open dialogue is a Finnish approach, working with people with psychosis, quite often first episode, but not only, in Lapland. They work with a team, a multidisciplinary team, where everyone has been trained to do family therapy. They are not necessarily doing family therapy, but they are influenced by the principles of family therapy. And they start the sessions by saying, and by meaning it, that we, the professionals, do not have the answers to the fact that you have experienced psychosis. But together, maybe we will find the answers. And they invite family members, they invite neighbors, they invite friends, they invite employers, depending on who the client says are the important people in their lives. And the results, we have now a result of 10 years, of year after year. Most of the people in this study have been on minimal medication for not more than 6 weeks. And they had to justify why they want medication. They are not given medication because the professional wants to give it, but because they say they would like it. And then it is reviewed. Most of them managed to move from being in a psychotic state to going back to training or employment. Moreover, the rate of new cases of psychosis in the whole area has gone down by 2/3. And when asked, what is the explanation for that? They are saying, we think that people heard about us, that we are doing something good, and they come to us early before the crisis. And so we work in a preventive way from the very beginning. Enough about other experiences. What are we trying to do? I have to say that my funders demand that I will say it, that the views that I'm expressing here are not those of the National Health Service and are not the views of the funders. They are only our views. Okay? It's not only that, whenever I give a talk, I have to send them a copy. Okay? So, very interesting censorship. Yeah. Okay. It's a partnership between Cambridgeshire and Peterborough Foundation Trust and Anglia Ruskin University. As I said, we have service users, providers, and researchers. And we focus on the process because we want to create a truly collaborative relationship between clients who take medication and those who prescribe the medication. We want the participation of adult service users who experience psychosis, active participation in their own treatment. And we developed also some tools to aid the process of shared decision making, which I will describe. Maybe I can say now, the tools, we developed 3 tools. We have a very big website that everyone can look at. I think I had it it's at the beginning, but I can write it on the wall. It's a very simple website. But the tools are available to people who do not use the internet. A lot of the people we work with do not use the internet. Some have, know what computers are like, many do not. And the trust doesn't have any facility where people can use computers, basically. The first tool is a feedback tool. Before the person comes to the meeting with the psychiatrist, they have to think what they want to say. What are the questions they want to ask? What are the problems they have experienced with medication? They may be happy, they may be not, but it's a tool that allows them to think in advance, to organize what they want to say. This is not only for the sake of doing something in an orderly way, but this is in recognition that a lot of people have been used to being so passive in the relationship that they haven't got a clue of what it's like to ask things, even if they are critical of the approach. So it's how to present your criticism in a way that the other side will listen to you. So not to suppress the criticism, but to find a way that it will be possible to ask. The second feedback is at the end of the meeting with the psychiatrist summarizes in writing, not on the computer, what have we decided together. And this could be we decided not to agree together, or to agree to reduce the medication, to increase the medication, to move to another one, to stop to take it, the whole lot. And to give a copy at the end to the client, literally a paper copy. Usually the psychiatrist writes to the GP anyway, to the family doctor, but doesn't give the patient a copy. So this is to stop the communication about the client without the client. And also to write down the shared decisions. The third form is only for the patient, client, service user, to decide what long-term, thinking a year in advance, where do I want to be in a year time in relation to medication? Where do I want to be in relation to other areas where medication impacts? Like if I want to be employed, I need to be able to get up in the morning usually. So how do I get to that stage? Or I want not to put on so much weight. I want to have back my libido. I want to have sex, yes. Most psychiatrists, by the way, find it very difficult to talk about sexual functioning. It's a very embarrassing area for them. And they admit it, yeah. So these are the tools, but this is really not enough. What we did initially, we did a literature scoping review, and we consulted separately service users, care coordinators, i.e. the non-psychiatric staff, and psychiatrists. What they think about shared decision making, what image do they have about shared decision making, what do they think are the obstacles to reach shared decision making, what are the opportunities to reach it. The decision to have it separately and not together is because we were convinced, and I think we have good reason for that, that none of the 3 groups would feel safe enough to talk honestly in the company of the others. This is where we are. The clients certainly will not feel assertive enough in front of psychiatrists and the other staff. The psychiatrists will not say what they think in the true way in front of the others, and neither would the care coordinators. each consulting session was led by 2 people, a psychiatrist and a service user trainer, so that the shared element was there as a model from the very beginning. On the basis of the literature review, the consultation exercise, we developed training programs. Again, separate training programs. We worked only with people who experienced psychosis. In a sense, the most difficult problem in mental health services. We could have started with people with neurotic depression, but the issue of medication is much more pressurizing in the psychosis area. So we then provided training, and we did a before and after evaluation. Our after evaluation is a year after the training, so we can see if it made any difference. Here you have a lot about the evaluation, which I don't think I'm going to go into, but the primary outcome was reduction in conflictual decision making. So the conflict is there, but people are able to reach decisions around it. That there are a lot of things about options, about the CSSRI is about the socioeconomic state of people, the housing, who they live with, how much income they have, because the issue of poverty is a real issue here too. Recovery Star is about where they are in recovery, attitude to drug taking, and things like that. The challenges, I think it should be quite clear what are the challenges here. They are about the meeting of 2 very different types of knowledge. We are trying to force, if you want, the meeting of the experiential knowledge, the lived experience, the subjective knowledge, which we call non-scientific, and what is called, coming from medicine, scientific knowledge. I think basically what we are saying is the scientific is not that scientific if it excludes the lived-in knowledge. That the true knowledge is a mixture of the 2. So our solution to the challenge is to say experiential knowledge equals scientific knowledge. And we are going to use both. We are going to make it possible to access information, to understand information about psychiatric medication. Because a lot of what we were told is people do not have the information. We think this is true, but people do not, it's not only about having information. You can find the information on the website. But how do you evaluate the information? And if you are not using computers, you can ask your friend who is on that medication. But how do you evaluate it? And it's quite intriguing. The Trust has pharmacists who are available. People can come to the pharmacist. It's actually a very dedicated group, ready to give the whole information. In truth, it's not the whole information. They only give you information from the psychiatrist's perspective. The information from the service user perspective is not there. So again, what we have as scientific is a one-sided piece of information. It has a list of side effects because it's very difficult to deny the side effects. But it never says people feel that way or people have experienced it in that and that way. So, the third challenge is to actually share power in those meetings. Even if you have the forms and you gave people training, are they able, after the training that we gave was to the service user was the longest. It was over 3 months in sessions, in very interactive sessions, always in groups. Will they be able to actually be assertive enough when the psychiatrist says, but I think? And the psychiatrists are actually trained, and they acknowledge that. A lot of their training is in persuading people in a polite way, telling people what is good for them. So it's quite problematic to challenge that. So what have we learned? These are the consultation groups. What is interesting here is people said, all of them said shared decision making is wonderful. We want to be there. But there was a very long list of why we cannot be there. We can't be there because people in an acute episode they are out of their mind. They do not live in reality. If we take the wrong decision, this will be very risky. So it's a risk we need to avoid. We don't have good enough information. And a lot of people actually want the doctors to make the decision for them because this is how they've been socialized to for years. This is how we are socialized as a society. It's only very recently that we start to doubt the value and the wisdom of medical decisions. And they say especially the patient are saying we do not have a trusting relationship. And so we cannot really have shared decisions if we don't trust that person. What can facilitate? They said good enough information, evaluating the information, feeling listened to. This is back to what I said yesterday about recovery. Study after study says feeling listened to, feeling taken seriously, being taken seriously is the beginning of trusting, the beginning of a recovery, because it's not just about trusting the other person, it's the sign that that person trusts me, and I am someone who deserves to be trusted. Some people said it's good to take seriously what a person has to say. People spoke about, I am treated as a symptom, as a collection of symptoms. I'm actually not treated as a person. The doctor is interested how to reduce symptom A, symptom B, symptom C, but not trying to understand me first, because I'm not just a collection of symptoms. So they felt very depersonalized in the relationship. And some people spoke about the involvement of care coordinator, family members, and friend in this process. We did a training in small groups because we thought only in small groups we can get the interaction going and enable people to think more seriously, to share with each other. What do you think are the people who liked best the training program? We have 3 separate parallel training. Who liked it best? Service user, non-psychiatric staff, or the psychiatrist?
Psychiatrist, of course.
And who liked it least?
Coordinators.
It's actually the patient who liked it best, the service users, because of the sense of being listened to seriously, and also for being allowed to express the doubts they have for many years about medication. We never said you shouldn't take medication. We never gave any advice how to come off, apart from saying if you want to come off, go and consult with a long list of people, organization, and so on. We never suggested to anybody any individual decision. We said from the beginning, we are not going to offer personal advice. It's not our place. We are not a clinical team or anything like that. But what they liked, as I said, is being listened to, the opportunity to learn from each other, as well as from the people who were running the group, who were a psychiatrist and a service user trainer. And we know that a lot of them stayed in contact with each other as well. The people who liked it less, of course, the least are the psychiatrists. They are very critical. They say that we didn't treat them with the respect that they deserve. Even though it was someone that the consultant psychiatrist who led the work with the psychiatrist alongside the service user trainer is someone I think they really like very much, and they value her contribution. I think they came to the group only because of her. But interestingly, she felt the need to bring a very nice lunch. We didn't fund the lunch. We funded refreshments only for the service users. But she brought a very nice lunch for her colleagues. I was at the first session because I had to give the part of the research evidence. So I stayed for the end of the session. And I could see how differently they treated the service user trainer, who is a worker in the trust now. She is a service user, but she also trains the peer support workers. A woman with a lot of experience, not only as a patient, but also in running services for homeless women, a lot of other things. They were not really listening to what she had to say. They didn't say that. You could see in the body posture, in the lack of response, how they're not listening. Okay, small groups, interactive. In the work with the service user, we not only looked at the process or the evidence, but we also did a lot of training on becoming assertive in a positive way. We thought that if we do not do that, they will never be able to move to the next stage. And as I said, service user, yeah. And this is what the service user said at the end of the training. This is not the 1-year follow-up. But you can see how they were really pleased. The only negative comment we had is, why was it so short? So what they liked is that they were listened to, that the material was inclusive, well presented, that they think that it was empowering, and why didn't this happen 20 years ago? When we go back to the professional participants, people agree that preconceptions were challenged, that it was a positive learning experience for some, that it gave them time out from other activities to focus on that. It stimulated thought and discussion, and it gave them an opportunity for a frank discussion. What the service user trainers said is that they gained confidence, that their personal experience was genuinely appreciated, they felt valued. The refreshing experience was of working with a professional colleague as an equal. And they learned more about the difficulties the professional face, because it's not a particularly easy job to do all of that. So, we are now, our sample at the end was 15 psychiatrists, 35 care coordinators, 47 service users. We wanted a lot more service users, we wanted 70. We had lots of problems in recruitment because our gatekeepers were the professionals. We could not approach anyone, our ethical permission doesn't allow that. Only they can talk to their patients, and if the patient says yes, then they can give us the name, and then we can contact. But they selected, of course, who they think can benefit from this program. And anyone they thought is not going to benefit because they haven't got insight, which is another interesting term, then they cannot ask them. And after that, of course, there were quite a number of service users who felt very insecure and some people who just want that other people will make the decisions. We haven't got at the moment the post-program evaluation. We are just doing it. So I can't tell you much whether it was successful apart from the good evaluation of the process. But I want to share with you one example of the conflictual scenarios we use for discussion. We invited actors, professional actors. We gave them scenarios that are based on true stories that we took from service users. And about, situation where it's not easy to reach a decision. There are pros and cons for any decision. So I thought maybe I can show you some of those, and maybe you can then discuss them, whether, I don't think that I want you to be in the role of anyone, but how would you continue from the point where the scenario stops in terms of the process of shared decision making? Okay? Moita, I'm not sure I know what to do. Husband to the family doctor, because the psychiatrist told her that she has to change the medication. Because she has been for years on a medication that enables her to sleep at night. But that medication has a very high chance for her to develop heart problems. And so the psychiatrist is saying, move to another medication, gave her the name of the medication, and said, go and discuss it with the family doctor. And this is what she's doing. And you can see her doubts, how the GP is behaving. Our family doctors are very important because people do not stay in hospital, they hardly ever stay in hospital. A lot of the work is done in the community. And the psychiatrists tell the GPs what medication to use. And if people come after 1 month or 3 months for a new prescription, they will go to the GP. And usually they know the GP, because the GP is someone they met quite regularly. They don't see, unless they have a crisis, they don't see the psychiatrist for more than twice a year for a review of the care program and the medication. Yeah, it should be there. It was there.
Yes, yesterday we found it.
It's the one with 3 people here.
This one.
Yes, this one. You can enlarge it. No, not this one. The 3 people. You have it in here. Yeah. Yeah. Yeah.
Look, I've been on this amitriptyline for 25 years now, and I've been on it a long time. My psychiatrist has been talking to me about the possibility of changing because I've got some worries about the amitriptyline now.
Yep.
Some sort of side effects I've been getting with it. I've had the one where I'm quite drowsy a bit, quite a lot, aren't I?
Yeah.
But if I cut it down, I'll start then getting insomnia and I'll start getting agitated and I get a bit anxious and I can't
sleep at night, then I know about it.
I know. Well, so although I've been drowsy and I've had problems with like my water retention sort of thing, but I've managed to put up with that because it makes me feel all right on a tablet. I've been quite good on it, haven't I, over the years. But now, you see, I was reading. I was telling my husband, I read in the paper the other day about people that have been taking this drug for a long time having heart problems, and I get really breathless when I go up the stairs, and I'm a bit overweight at the moment. And I know. you know, I'm worried that I'm going to get a heart attack or something because of the, you know, because I get out of breath, and I'm concerned about that. So, you know, he said about this other drug, this nortriptyline, but you see, I'm anxious that if I don't take my drug I'm used to, I'm going to get ill again. So I don't know what to do, really.
No, well, I had a because I had suggesting that you changed to nortriptyline. For all the right reasons, I'm sure. I mean, to be honest, this is an area in which he has greater expertise than I do, so he's suggesting for the right reason. And he's suggesting that you'll be able to do this gradually and gently if you're working with R&R, who I believe you've met already.
Yeah, I have. Yeah, they're very nice to me up there.
Good.
Yeah, they're very nice.
Yeah.
I do, yeah.
That's fine. He also tells me in his letter that your husband is due a holiday, and the fact that you're going to be able to take
I've got 2 weeks off. I wouldn't call it a holiday if I'm going to be looking after you, but anyway, I've got 2
Well, you
weeks.
don't have to bring that up now. You know, you can help me because he said you need to help me.
I'm just saying,
Yeah, you'll be there to support her.
Yes.
So this will
probably
be...
do driving.
Well, you will have to do a bit of driving. If I feel anxious and I'm not,
Anxious, yeah.
you know, because he said it would take time to go from one
That's right,
one
you're
to
right.
the other.
Yeah, but it's called titration.
Yeah,
It's
that's
a
it.
titration. It's a period during which you will be weaned off one,
Right.
and then moved on to the other one.
Right.
And that, to have your support will be invaluable.
Yeah,
And
you can help me out because I'm not well.
Yeah, because you won't be right, will you, in that period? Because once you get below the 75, you struggle, don't you?
Yes, I know, but that's my worry, isn't it?
We're taking that one down. The other one will be building up, and hopefully will be giving you a better result without the concerns that you have at the moment.
But you see, what about this new drug, this nortriptyline?
Yes.
Well, I mean, that might have some nasty side effects as well.
Well, I'm sure, as you say, that it may well be. Let's have a look. I can print out her. Here we are. Collected on the way out. I've sent to the printer a list of all the potential problems with the new one. But
Does that make you drowsy?
I don't know. Let's have a look. Well, you know, it's always going to be a case of getting what's right for you and what's best for you. And if your psychiatrist suggests that this is right, this worth going with, and sorting out in the very capable hands of R&R with whom you get on well. And your husband at home to help. I'm sure we can make this work well.
I hope so.
Yes. So I will reply to him and say, yes, okay, let's go with it. And I'll be here to support you in it as much as I can as well. I mean, it's true to say these guys have much greater expertise than I do in this area. You know, GP doesn't, we do have so much to know. But do you have any other questions? I think it's worth going for, and it seems to me the timing is just about right. Right. Lovely, well, nice to see you. Thanks both of you for coming in. And hope it all goes well. Well, keep me informed.
Yeah, we'll do.
Yeah. Okay.
I want to show you another clip from another case. Can you come? This case is about a woman who tells the psychiatrist after 28 years that she has been on antidepressant that she is coming off the medication. And this is this one. Okay, you will see what happens
Very
next.
nice to see you. I'll see you again next time. Okay?
Thank you. By the way, I come off medication.
You certainly gave me a bit of a shock last time you were here. Just at the very end then, telling me you've come off your medication.
Yes, indeed.
Right. And how are you feeling?
Yes, I'm feeling very, very good. Thank you very much.
Okay. And when exactly was this?
It's probably about 2 weeks ago. On this.
2 weeks ago, right?
Yes.
Okay. I have some reservations which I shall tell you about. Now, first of all, can I just ask, how's your husband feeling about it?
Well, of course he's concerned about my well-being, but on the other side he's terribly supportive. So, you know, on the grand scheme of things, he can see that I'm doing actually quite well.
Good. Good. I'm pleased for that. Let me just tell you why I've got slight reservations about you coming off so abruptly. We know from experience, and I think actually you know from experience too, that sometimes coming off a drug that your body is quite used to, coming off it very suddenly, can, after 2 or 3 weeks, maybe even a little longer, cause some side effects. Your body is not used to being without it. Cause some side effects which can be very unpleasant. I know you've had insomnia in the past, but really acute insomnia, shakes, chills, headaches, all sorts of quite a wide range of pretty unpleasant effects. What would worry me about those things happening to you is that they might make you very anxious. They might drive you back into another depression. And you might actually find that you take the 2 steps forward only to go 3 steps back and be in a worse position than you were when you started this, and that we don't want to happen.
Well, to be fair, I feel that I've been quite sensible about this because I know in the past I have come off medication terribly abruptly and I have suffered the consequences of that, and I do, I have had help for that in the past. But this time, after all the things that has happened since I've joined my thinking about medication group, all the advice I've had, I feel that I have actually turned a corner, and I don't feel that I've come off the medication that abruptly. I mean, I was very sensible because I did meet a lady who was a born-again Christian before I went to China, who did say to me, you won't need your venom vaccine. You won't need it when you're in China. You can forget about it. But I didn't. I took it with me. And I took my medication as prescribed. It was only when I came home that I realised that there were some days that I was forgetting my medication. And it got to about 4 days, and then I realised, actually, I might as well come off this. You see? Because I'm feeling okay.
Yes. Well, as I say, I'm really pleased. I'm really pleased that you feel you want to do this, that you feel strong enough to do it, and you have the confidence to do it, and your husband is supporting. All of those things are very, very positive, and I'm pleased with it. My recommendation would be, however, to avoid the pitfalls that I mentioned earlier, that you perhaps go back onto medication, a liquid medication. I'll tell you why in a second. Well, I'll tell you why right now, actually, because it's much easier with a liquid medication to reduce it, little by little, step by step. Otherwise you have to cut up pills and things, which becomes almost impossible after a while. So you can then reduce the medication, taper off your dependence on it over a period of time, maybe even a couple of months. We have found, there's a lot of evidence for this, we have found that people have much more effective results from taking that path, rather than, as I said, this rather abrupt path, which, as you know yourself, can be not disastrous, but unhappy and ineffective in the end. And I would like this to be as effective as possible for you.
I have come off the medication abruptly before, but there was no time where I knew about a fluid that I could take or come off it gradually, because I've always gone straight back on medication. I've been told to take it all the time. Nobody has ever advised me of, actually gradually coming off it, even with the venom vaccine. That didn't seem to be an option at the time. So, to be fair, that's where I'm coming from at the moment.
Yes. Well, at any given point, we prescribe what seems to be the best option for you at a given moment. And then the vaccine has been very effective for you in lots of ways. But the fluid hasn't always been available. There have been ways of tapering off, but on this occasion, you have come to this decision yourself. You have come to the point at which you decide you want to take control. And I think that's the best moment at which to do it. So that's why I want to be as supportive as I can. But I can't enforce any opinion of mine. I can only recommend it. I would just remind you that, as you've said yourself, coming off fairly abruptly hasn't always been successful for you, and I just don't want to repeat that piece of history.
No, and I'm very grateful for your advice. It's just that, you see, with the group I'm in at the moment, the Thinking About Medication group, we do have some, forgive me for saying that we have some very good health professionals there who do help us through, and with the support of all the other people and the way that we can talk to each other, you do tend to gain confidence from that. Now then, you see, I have learned that everybody's always saying, oh yes, it's a chemical imbalance of the brain, depression, chemical imbalance, but there is actually no test to see if there is a chemical imbalance. So what they do, they tend to try things out in our group. There are a lot of discussion. They give us a lot of tips about exercise. You know, I mean, I'm drinking so much more water now than I ever did, as I was on the teas and coffees all the time. And they do say that you need to hydrate your brain to make yourself feel better, which is something I've been doing now for quite a while, which has really helped me. On top of that, I've reduced my sugar intake, which is another piece of advice, which has helped me immensely. Because you see, I was losing sleep, as you know. I mean, I was a terrible insomniac at that time. And also, when I did come off the medication abruptly, as I did, I do agree with you, you know, I mean, my mood swings were terrible, you know. So, but now with all, I've put all these things in place, I'm trying them out, it seems to be working very well for me. And I do feel confident that I have turned a corner. And while I appreciate what you're saying, and I will consider it, you know, I'd like to just see how this goes, because it feels different to me.
Well, I'm not going to enter into a long discussion about any of these things. There's no point. I'm very happy for you, as I said, that you are feeling so well at the moment. You have my recommendation. It is my very strong recommendation, but it's your choice to do as you see fit. All I would say is that if at any point in the next few weeks or indeed months you feel any of the ill effects of coming off the drug, or indeed simply feel yourself slipping back into the kind of depression we both know you can suffer from, if you feel that coming on at all, please get in touch. Please get in touch straight away. Don't leave it too long. I won't necessarily fill you full of more drugs, but I would like to be there to help. So, if you're not going to take my advice in the first matter of coming off gradually, please do take this piece of advice and come back at any time you feel you're in trouble.
Well, that's very kind of you, and I will. Thank you very much indeed.
Indeed. The very best of luck to you.
As I said, these are actually based on true stories, including the one of the woman who stopped after 28 years.
And I have to say, I'm feeling very well indeed. I'm very grateful for all the advice and the medication.
So what I want you to do, you can choose one of the two scenarios and try and write down how you would, or maybe discuss it with the person sitting next to you, how you would continue this dialogue as a professional. Okay?